Hi guys. Hello.
Hello. It's the two of
Hello.
us. That's
Welcome.
it.
Welcome.
Where are the rest of our speakers?
Yes.
Welcome, madam.
Yeah,
Hey, how
hello.
are you?
Hello.
Oh,
Welcome, Dr. Vishal.
thank
Thank you for
you.
joining us this Sunday. Thank you so much. I'll have to add this again. Then invite again. Hi everyone. Hope you're having a great Sunday. Hello. Hi. So I'll quickly introduce. I think Dr. Tosif he hasn't joined, no?
He hasn't joined, yeah.
Hasn't joined. I think he's fixing his hair.
It's too cold
Or
over there.
So
oh,
I
good.
think he's getting cozy.
Yeah. Yeah. Okay. Until he joins, I'll just quickly introduce Ed. So first one we had Dr. Vishal Gandhi. You all know he is the FIR specialist, and yeah, he's very famous and for his amazing fracture instrument retrieval cases. And okay, Dr. Tosif is yes. Send him again. Yes, and our second speaker is Dr. Atif Nathani.
hello.
He is
Hello,
Hi.
hello
Mumbai.
guys, how are
He's a
you?
microendodontist
Hi.
from Mumbai. And our third specialist, Dr. Tausif Nathani. Hello.
Hi, finally.
Finally. He's a specialist endodontist and from UK, and he's done his PhD, he's done his MDS, his MS, and then PhD from Spain, right? Am I right?
Yep, yes.
And then he's working currently as a specialist endodontist in UK since 1.5 years in UK.
Yeah, around a little shy of 2 years, yeah.
Yeah. Okay. So we're here, all here to talk about negotiation of calcified canals. And I think about 100 people are live. I think we can start with the topic of the day. Okay, so quickly going to talk about negotiating calcified canals. How do you proceed? How do you do treatment planning? How do you look for where to start? How do you decide your armamentarium? How do you negotiate? How do you find the canals? And we're going to cover all that. So yeah, super excited for that. Okay,
We
so
all are.
we have divided it into a few parts. The first part would be mostly, for example, the patient is coming in, and the first thing that you do is take a radiograph, an RVG. So that's where you start. Take an RVG. What do you see in an RVG? That's the simplest thing. So if it's a obliterated chamber, you'll see that there's some radiopacity in the chamber. So that's where you start. You can suspect that there's a little bit of obliteration. Then you can find breaks in the canal in the RBG. So that's where you start a little bit. And if you feel that it's a suspected obliterated chamber, so how do you proceed with it? I want Dr. Tosif to take over. Like, how do you proceed if you feel that this is going to be a tough case for me? It's going to be a case with obliteration, and I might find some calcified canals. How do you proceed with the case further?
Right, so, I mean, to start with, the first thing I would do is, in any case, it's absolutely anything, either it's calcified or not, I would take two radiographs. We need two radiographs for endo. One is straight, one is angulated. That's the only way you're going to know the anatomy. That's the first thing you want to see.
Okay.
Now, obliteration or calcifications can happen due to a lot of things. There can be a long-standing caries. So calcifications only happen when there is irritation to the pulp for a long time, and that's why the pulp has created calcific metamorphosis to protect itself from the external stimuli. So could be trauma, could be a lot of caries. So you have to figure out what is causing that. Many times there are people who are grinders, and you never know, and their pulp chambers are calcified. So two different radiographs. That's one of the things that I would be taking the first. If the calcification is really, really like I can't even see the pulp chamber, or I can't even see the distal canal, for example, in the lower molar, I would go for a CT scan, which is one of the really, really good armamentarium that if you have access to, that's one of the best things. You can see a lot of things in that and get along around what you're gonna deal with before you even touch the patient. Then there are the other stuff that you can see. You can take before you access. You can take a bite wing radiographs. I know this is not very common in India, but a bite wing radiograph. If you don't have access to CT scans, you can always take a positioner. Take a bite wing radiograph. So before you access, what you can do is you can measure, especially if you're a beginner, you can measure how far the pulp chamber is, and don't go more than that. So that's one of the other things you can do. Of course, your diagnosis is one of the key factors. Calcification doesn't always mean root canals. You should have cold test. You should have EPT. You should see what's going on. You should see if it's necessary to do a root canal treatment, and only then proceed. And the other part is where, as I said, that there are grinders, there are clenches. So if that's the case, there's a lot of wear. There's something going on that you are like, maybe there's something else that's needed. So endo is not just you're first a dentist before an endodontist. So okay, you can do the endo, but then at the same time, you should also tell the patient that you need more further treatment, and then refer them to whoever it is.
Yeah, that's
Absolutely. I'll just add on to one to this. Like there's a lot of misconception where people think that the entire canal is calcified. The calcification basically we need to keep in mind is, as Dr. Tausif said, that it starts from the pulp chamber and then goes to the apical end. Right. So if you have taken a radiograph and you cannot see a canal, that most of the radiographs, they show you the canal till middle third and suddenly it disappears. That doesn't mean it's calcified. Right. So keep that in mind. There may be a curvature. All right. There's always a curvature or a bend which would not show the canal that you would expect to be to notice in a radiograph. So don't think that the chamber is calcified, then I can see the canal and again there is a calcification. It never happens that way. All right. So keep that in mind. And it always starts with some kind of irritation, some kind of problem which is there in the coronal end, probably microfractures or grinders or some kind of caries, and it will be a chronic lesion. It's kind of a defense mechanism, as he said rightly. It is a way of protecting the own pulp from the irritation and the constant trouble that the tooth is facing since a long time. All right. So we need to proceed we cannot do it casually. We need to proceed cautiously. We
Yeah.
cannot just jump into it, right? So keep that in mind.
okay.
Yeah, and even and you know even with this discussion, I need to raise one thing also, how you take your cases. So many times a patient will come to your clinic and he or she will ask, my tooth is got discolor, right?
Yeah.
So yeah, and there is no periapical pathology, not in 2D, not in 3D. So now I want to ask you three that how you take your cases. You go for the root canal or not?
I will take the sensibility test first, like a little bit of history, like why the discoloration, and if it's getting discolored, there will be some changes in the radiograph as well. There will be the chamber would have, it will start constricting a little bit. So I'll start with
Yeah.
test.
Ye-
So yeah, that's my.
Yes, 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 yes. So
There's
basically,
yeah.
please.
This has I've gone through a lot of cases like this. There's also something which is a little advanced, to be honest, but there's something called a TAP. It is transient apical break. That happens in a lot of trauma cases. Sometimes, in simple terms, there is transient apical break of the blood supply to the pulp. That happens a lot, and the discoloration happens, but you're not supposed to treat it. You can wait according to the guidelines. You need to wait. You see, and in the future, probably the discoloration will come back. So that can happen.
Oh.
Again, as Anukriti said, pulp sensitivity test and especially electric test. If it is positive, there are no symptoms, patient says, I have absolutely no problem. It's just a little discolored. Sometimes people are very concerned. Sometimes people are really not really concerned. So just do that. And then even after in the later stages, if the discoloration has not gone back, but the pulp sensitivity test is still correct, please don't treat. Just do an external bleaching, wait. If the patient's happy, you don't need to do an endo.
Okay.
Yeah, because
Don't complicate your life.
yeah, because I have seen, because we all have seen these cases. Like, so previous clinician has started root canal because the patient's chief complaint was just like discolored tooth. Yeah, and this is, I think, a good point to raise for our audience, right?
Yeah.
So they will, yeah, so they will understand which case to take and which case not to take. So every discolored tooth will not go for the root canal. What I say, right?
Okay.
So
So
I'll just add on that
Yeah.
if you take a radiograph and you only if I'm judging only on the radiograph, then you should at least see the periapical area, even if the tooth is discolored, but there is no pathology that you see. Please keep it under follow-up. This is what I would say.
Perfect. Yes.
okay.
Yeah.
So, to add on to CBCT, are there any specific settings that you use for the CT? Do you instruct for a small field of view, a high contrast, and how do you use CT for looking for your canals in the axial section, or how do you proceed with what is your CT settings or something about that? A little bit. Who's gonna take over? Vishal?
Is that question directed to me or Vishal?
Yeah,
Vishal said
you,
yes. Go
no,
ahead,
no,
go
Yes.
ahead,
you
Vishal.
only.
No, I just answered.
Yes.
I'll just
Okay,
add on after.
so for me, CBCT for this kind of cases is always has to be like a sectional CBCT, a small 4 by 5 or into 5 by 5, right? And the axial section is actually the most important, what I believe, right? But at the same time, I believe this also that even pre-op CBCT for this kind of cases is actually less important than the intra-operative CBCT. So, I want to raise even this point also that whenever, see, cause ultimately treatment part will not going to change, right? Even with the CBCT or without CBCT. So if you are starting a case and at the some moment you are not getting the canal, or maybe you are off track and you want to know where is the exact canal and where is the exact location. I think in my practice, how I proceed, if needed, then I will go with the CBCT. But if I'm not able to find even after the first appointment or I'm stuck in between, then I will go with the intra-operative CBCT. I just put a point of GP as a depth marker inside the canal or inside the troughen area, and then I will proceed with the CBCT. So that will actually tell me at what point I have reached and how far deeper down I need to go.
So basically trying
Okay.
to save patients money.
Yeah,
Pre-operative CBCT mat lo.
no, I'm
If
not
needed,
saying,
you take one.
yeah, I'm not saying that you should not take, but in
No,
many of
no,
the cases,
you're right. You're right.
Yeah.
yeah, cause this is another thing that people are going blindly with the CBCT, but eventually you have ended up with nothing. Cause have you got the canal? No. Are you on the right track? No. So if you have started and now you are not getting the right canal, then I think time to go for the CT.
Yeah.
So there are
100%
cases
agree.
where there are so many people who take pre-operative, intra-operative, and a post-operative CBCT as well. All right. I don't know if I should say this, but in India, it's a bit difficult.
Mm-hmm.
So
It's a
it's
bit difficult.
Bit
So,
difficult.
so convincing a patient to go for three CBCTs is very difficult. So,
But to
you should choose which one you actually need and it
Exactly.
will really help you. It's fine, and I totally agree with you. But I think at Tosif's practice, it's a bit different, where they go for a pre-operative CBCT, plan everything, and then proceed with an option of doing an intraoperative CBCT again, the way you have described right now, and if needed, a post-operative CBCT, and then a follow-up CBCT. So the way we take radiographs, he's taking CBCT over there. He's
CBCT.
flexible, so don't
Yeah.
worry about the radiation.
No, no, that's not what's happening here. I agree with Dr. Vishal. I think I do the same. And if I'm not able to find the canal, that's when I would take a CT
Yes.
scan. Unless I'm really, really, how do I say it? I'm in doubt or I'm searching for something before starting the root canal treatment. That's when I take a CT scan. I do not take intraoperative in case I have already have had a CT scan. Only in I think in the last 2 years I've taken once before and intraop because I was absolutely unable to find the canal. That's the only case. The other case about taking CT scans before and after, we don't do that. We only take one CT scan, and in 1 year follow-up for apical surgeries or a really huge periapical lesion, that's when we take CT scans. Something to note is that CT scans, especially for me, sometimes I don't charge the patient because that's an operating thing for me. That's helping me rather than, I mean, yeah, it is helping patient, but at the same time, it's helping more towards me. I take a very small charge, but that's probably not possible in your case because I have the CT scan inside our own practice. So that's a completely different choice and a completely different situations. But yes, there are really, really very good specialist endodontists that take CT scan before. It's a standard, no matter what you have. Normally, even a central incisor or whatever it is,
So
pre-op
for
you take
almost each
post-op,
and every case.
yeah, which I don't agree to, but then they do
See, everyone
they do it
everyone
really
has their
really
own
big
way.
names, yeah, really
Everyone.
big names. They do it, and but to be honest, here in the UK, it's really difficult to even justify. You have to justify even one single radiograph you have taken. If you have taken a radiograph and that radiograph did not come correctly, you have to justify why did not come correctly. And there are certain number of X-rays, so they can audit you. They can check 100 patients, they can check 100 X-rays, and if you are not over 90, that you are grading your X-rays as A or your X-rays have not come properly, you have to go and do a course. It's just like driving course. If you are not driving properly, you have to do a course before you get you. If not, you get a point. So it's radiation is something very, very controlled, at least here in the UK.
That's
Sure.
great. Okay, so we have the CT now. You're planning the case. Okay,
Oh,
so for example,
yes, something. Sorry, just before we cut off the CT scan topic. CT scan has to be small field of view, high voxel size,
yeah.
and there is also a possibility. I don't know if there is possibility of this in other situations. Depends on what your patients has. If they have a lot of implants, a lot of metals, there's also a 360 option, at least the one that we have in J Morita, where the machine just doesn't scan 180 degrees. It goes all around. What happens is the scattering is low, so you can see everything. The other point, because I have worked in India, the problem is CT scan reports come in X-ray
Photos.
X-ray films. Please
CT.
don't do that.
Yeah.
No
Please
DICOM
don't do
file
that.
here. We have to
Please
work a
ask for your
lot.
DICOM files. Yes,
It has to be,
ask for your
it's a
DICOM
3D.
files.
It's a 3D imaging, guys. So you
Yeah,
need a 3D picture. If you're looking at it in 2D, there's no point in doing a CT scan.
it's not. There's no canal there.
There's no canal there. It's like that. So I would highly, to wrap it up, I think I'll just add on a couple of things, which is like, at least if you have calcified canal, you can think of CBCT. If you have a re-RC case, you should think of a CBCT pre-operative, so that you know what's gonna come in front of you when you start the patient. And obviously, if you have a surgical case, you should go for a CBCT.
There are a couple
Okay.
of softwares you can download just for free. This is just basic information. There's Blue Sky, that's free. There's Romexes, that's free. There's you can get 3D from Carestream. Just download these. one of the softwares will open the CT scan because there's a lot of problems opening the CT scans. And the other advice I would like to give you is try and rotate everything and make the tooth straight in the CT scan. You will see a lot of things.
Mm-hmm.
True.
Because that's true. Whenever we have to send the patient to the CT center, and then that's where they send the PDF and their own report, which is of no use. But I always ask for the DICOM, and it takes another 2-3 days to actually get the DICOM. So that DICOM files. So yeah, that DICOM file is super important. And learning how to use working between sections from sagittal to, so yeah, it's a learning curve, but once you learn it, very easy, and it makes things very, it's much easier. Okay, so moving ahead from CT, I think CT took a huge part. Okay, so the next is, okay, fine, the next day you've decided that the next day you're going to do the start the treatment. So what is your, how will your armamentarium look like? What are the things that you want them to be there, like your burs, what do you keep, and yeah, little bit how you'll start. So Dr. Atif will start, and then we'll join.
Let
We'll join.
let me just say, it's better if I say one and then you can proceed. So I'll keep the set of birds with me. Anything
Okay.
else you want to add?
What kind of burs? Which burs?
So, set of burrs with probably long shank burrs, which will make it easier for me, and because we have already applied the rubber dam, we have isolated everything. We are working under magnification, so I don't want my burr and my aerator to take the entire portion of my vision, which will become very difficult. And once I'm done with the opening of the chamber, I would like to not proceed with the files immediately, which everyone does. Like, मेरे को जल्दी से जल्दी अपेक्स तक पहुंचना है, बिल्कुल नहीं. Endo is all about patience. Basically, it's you need to figure out the number of canals, the orifices, and I'm considering if you have a CT scan with you, you should know that whether there are 3 canals, 4 canals, the placement of the canals. At this moment, I would love to jump into ultrasonics, because ultrasonic tips which are available in the market, it gives you a very good control over the removal of dentine, taking care of the RDT, which will govern your prosthesis and later on the success and the prognosis of the tooth. You cannot just go into a canal thinking, okay, let me just get a lot of ditches with a round burr or a tapered fissure or a straight burr. We do not find canals like that. Even if it's a normal case, you cannot go in with a burr after a certain point of time. And that is what we people are taught, that when you get a ditch, when you get a drop, you should stop your burr. But in a calcified chamber, I don't think that will be possible. For you to tactile, you feel that tactile sensation that you have got a drop over there, because everything is stone over there. It's like kidney stone, gallbladder stone, there's a pulp stone. You cannot feel that drop. So you should at least have that like dimensions in your head that you can go only up to this level. And after this, even if I don't feel a drop or anything, I will start using my ultrasonic tips. And immediately after that, because there are tips which are used to remove the dentinal walls, clear up, take it into a straight line axis. Then there are ultrasonic tips that have a pointed tip in the front, which helps you negotiate that canals if there is an MB2 or a middle mesial or some kind of an extra canal. And in calcified cases, you may not be able to find the normal canals, which are primary canals also. So you should definitely keep a couple of tips, ultrasonic tips in your armamentarium. And after that, I think we should proceed with the files. DG16 especially, it really helps, even if if you are getting confused, or if you're getting scared a little bit, whether it's a perforation, whether it's a canal, and you're not able to find it. DG16 really helps because of the angulated tips. It can go in various shapes in various areas. And as we all know, the start of any canal is never ever straight. That is why we are trying to get into a straight line axis. We get into the canal orifice. Don't be in a hurry to reach the apex, because especially in curved canals, in calcified canals, you cannot expect to get into the canal through and through in the first go. This is not your mentality. This should not be your mentality to directly go in. You're
for
not
any
doing a
canal.
upper central. You're not doing a canal which is like an upper central, which is like huge. You can go in and sit and do it. It's like that. So calcified canals and thin canals and curved canals, you should always be very careful. So this is what will be there in my armamentarium, along with a little bit of liquid EDTA, not the gel, the liquid EDTA, which will help soften the dentine a little bit around the orifices, so that it becomes very easy for me to feel that catch of the entry point.
Okay. So are there any specific tips that which tips do you use? And yeah, I want the answer from all three of you. Which ultrasonic tips do you prefer for like for your canals, for your, if you're looking for calcified canals?
So there are a couple of companies which give a lot. I mean, Woodpecker is also there, Dentsply is there, Satlac is there, and there are local companies as well. But the understanding of the tip really matters. And I feel if you want to trust, Satlac and Dentsply gives a lot of variation, and you can select whichever tip you actually need. So I have a set of satellite tips, Dentsply tips, and a couple of woodpecker tips. And wherever it's needed, I will select the same.
Okay. And what about you, Dr. Vishal and Dr. Tosif? Which ultrasonic tips do you prefer for your calcified cases?
We can't hear you, Vishal, sir. I'm not sure if it is just me or.
Yeah, we can't hear you.
Dr. Tosif, you
So
can take while he's trying to.
yeah,
Right. So, some things I want to add to what Dr. Atif said, and some things I can just give you names, because there are some people who have commented as well. Please elaborate more than same on ultrasonic tips. Basic, you can start with. There's something called from Dentsply. It's called Start X tips. These are the tips that you can use for modifications. So number one tip is the one that you can use for modification, and number three is the one that Dr. Atif said, that has a sharp tip, and you can remove the calcification or find different canals or remove the dentinal lip. The other thing I would say is, whilst we are still in the pulp chamber, if you know the laws of endodontics, so there are different laws that have been written everywhere. Just open any book of endodontics and you'll find these laws. So there's law of centrality, law of concentricity, there's law of CEJ. So I don't want to go into the details of these laws, but you can read through it. Law of symmetry and law of orifice. So all these laws, if you know these laws, absolutely any endodontic treatment will be very easy for you, because
yeah,
at the end you don't want to go more than the CEJ. If you can just measure with your probe how deep you are. If you want to put a rubber stopper on your long shank round burr and don't go more than that, you will never perforate. It's not going to happen.
absolutely.
The other thing that I have been using these days, apart from ultrasonics, and I've slowly reducing the use of ultrasonics, is the Munster burs and the endo tracer burs. Basically, they are slow speed, long shank, round rose head burs that you can use as ultrasonics. They are really, really good in removal of calcification, really good in removal of dentinal lips, and all of those things. And that's about access, and then we can speak about files afterwards. We'll just wait for Vishal, sir.
Hi,
I think
Vishal,
to yeah. Can
you try to
you
talk?
say something,
Yeah.
Vishal? No, we can't hear you.
Disconnect your AirPods
Maybe
from via.
maybe you have clicked on the
Mute.
mute button or something.
So till the time I'll just tell you a little bit more about these tips. So there are few tips which have a diamond coating on it, the ultrasonic tips,
Yeah.
and the regular tips that we have all seen the carbide burrs.
Yeah.
The carbide burrs have blades on it, right? So these ultrasonic tips, they are in an angulated form and they have carbide burr kind of blades on it. They Now remember, the ultrasonic tip is moving in one direction. It's kind of a frequency, right, that we cannot see. That's why it's known as ultrasonic, because it's not visible. It's not sonic. And when you touch this tip towards the wall, it comes, if you're not using, I mean, you should use it with water, but just for your, for you to understand, you can pick up an extracted tooth and use these tips. You will see a powder like substance coming out, right? This means it's in a controlled way. You are able to remove the dentine and the dentinal walls surrounding that entire pulp chamber, which will give you access, and it will not leave any kind of remnants of the pulp chamber inside it, because everything is visible. And apart from that, the number three that Dr. Tausif said, the Dentsply StarTex tape, it has that pointy head onto it. Now the biggest question that we all face as an Indian dentist is, ye kitne ka hai? So we should not get into the pricing of it. If we get into the pricing of it, I think we'll all just reject it. So let's think about quality. I think
But I
it
think
is a
I should all Atif, you should mention how long they last, please.
Yeah, they like.
Absolutely, and I'm coming to that same point, that it may be a hefty thing on your pocket, but it will last for a long, long time. It will last for a long time. It will be like, hardly when it comes to like discarding that tip, you will imagine that you have just spent 50 or 80 rupees per case when you use these tips. So don't get into the pricing factor, because if we get into that, then everything goes south, because the kind of treatment that we want our patients to have, I mean, if you're not comfortable, you should charge more so that you can give them the quality treatment, and don't think about the pricing. I would suggest, if you are thinking about a little bit economical range, you can go in satellite
Woodpecker.
tips,
Woodpecker.
woodpecker and satellite
Yeah.
tips. So at least, but the only problem is with woodpecker and the other companies, I'm not blaming anything, but there is a difference in quality. They will do the same thing, but it will not be the same for a long time. And you will be able to do the same thing with a Dentsply tape or a satellite tape for a long time, because of the quality and the make of the material. So I'm not blaming any company, and I'm not giving you any kind of suggestions that do this or don't do this. But I'm just saying that ultimately, when it comes to economical practice and a good practice, you land up spending the same amount. So rather get into a good stuff
No,
stuff
correct.
from the start.
Correct. Okay.
It's like loops are available in 5,000 rupees and in 5 lakh rupees. So 5,000 will cause a lot of trouble, and the other one will definitely be a quality practice and a good thing for you.
Correct.
Yeah.
Is still not audible.
Vishal sir, we need you to go out and come back.
Yeah. Exit, then we'll invite you again.
Yes. So
While I'm trying to invite him. Okay, so we've done that. Okay, we've negotiated. Now for example, you found the catch. Okay, that's your file. Okay, is he back? Yeah. Ah.
Now,
Yeah.
There you go.
can you
yeah.
hear me,
We
guys?
got you back.
What did you do, man?
Okay, I don't know.
Go ahead.
Anyway,
From now until the
I
end, it's
think,
all yours.
yeah.
Yeah.
Now I will speak for next 1 hour.
Perfect.
So, so as actually Atif mentioned about the loops, so we all need to understand one thing. The calcified cases, or I think most of the or all endo cases, microscope or at least a good 5x magnifying loop is. I think I should use this word mandatory. What do you say, Atif?
Absolutely
100%.
Right?
right. Absolutely. See,
Yeah,
we are
yeah. So
progressing. We are in a progressive world. We cannot stay back. We cannot be in the back seat and say कि नहीं 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 मैं तो जैसा पहले करता था मैं वैसे ही करूंगा.
yeah,
It's not like that. You have to upgrade yourself. That is why we keep on learning, and learning is going to be endless. Even we at this moment and our seniors who have taught us, they are still into that learning phase. So we cannot say that I will not buy a loop, or I don't need magnification. And the second myth is like I don't need an apex locator to determine the working length. It is not like that. There is a reason, and there's a specific way to do certain things, and it's going to help us. As the AI tool is again getting into medical and in neurosurgeries, we are also upgrading ourselves, and we are also getting into new stuff, and we should learn it. Absolutely, there will be a learning curve for anything. So now we
yeah.
can
So
talk about it.
so the thing is, the calcified cases. actually the most important thing is we need to understand is the depth, right? Cause as
Correct.
Atif mentioned that we all been taught to get a drop fill.
Absolutely.
Now understand the value of magnification, because you are getting a drop, but that is actually perforation, right?
That may be appropriate. Yeah.
So to sum up our discussion, the first thing I need to like mention that you do not need to use burr to search canal.
Absolutely.
Yeah, you just have a 5 mm depth first with the burr if there is a normal anatomical case, and then use your ultrasonic. And Tausif and Atif has already mentioned about the tips name. To add on this, one burr I use, another burr that is from SS White. I think you guys are using maybe that is your EG burr, Endoguide burr.
Endoguide
It is a
burs, yeah.
flame shape. Yeah, it is a flame shape burr, and you can use that for your, especially for anterior, lower anterior cases, right?
Correct.
Same as your Muntz burr or same as your Meisinger burrs.
Yeah.
Correct.
Yeah. So and about magnification, it is actually the most important and most basic tool for this kind of cases, what I believe.
Yep.
Because as we all are using microscope, and even we are not using microscope for some of our cases when we are in consultation, especially me and Atif or maybe
Yeah.
Anu, right?
Yeah.
Yeah. So in this case scenario, we understand that what is the actual importance of microscope,
Absolutely.
as we are doing both of the dentistry, and for especially this kind of cases, we all like understand that we need to run behind, as Tausif has mentioned about the law of this orifice location, and law of this I mean what you
Bob
say,
century.
this yeah, all laws of the most important law, we all understand that law of color change.
Law of color change, yes.
Yeah, and I always say this, without magnification you are not able to
Not able to.
differentiate between the healthy dentine and the pulpal floor. So
Healthy
it's
dentin,
always about
pulpal floor, and the stone.
stone. Yeah. So what is there in the pulpal floor, I mean to say. So most of the
Absolutely.
times, if you are not able to actually read pre-op IOPR very well, and you are just like in this manner that you are going zip zap zoom करके सीधा अंदर घुसे, and then at one moment you will stuck. And now what you will do? You will use burr. Eventually that will lead to the perforation. So I think this color changes, according to me, especially for this calcified cases, or those type of cases where you are not getting the canal, the law of color change is actually so important. And this law of color
100%.
change comes into picture only and only when you have a good magnification. At
Otherwise,
least,
everything is dark.
yeah.
Anukriti,
You look at
Otherwise,
it
our
with
everything
the
next
is,
naked
post.
eye.
yeah.
Everything is dark. Can't see anything. It's like a black hole.
Yeah.
Anukriti, this should be our next post.
Yeah.
All the laws.
I think I will make, because when I see when some of the cases get referred and then they can't find the canals, I see that they took their burr and they made the whole the floor flat, like a box,
Yeah.
trying to find
Yeah.
the canal. Just close their eyes regarding the laws of the centrality and the orifice location, and just made the flat. Now if the floor is flat, there is no anatomy, there is no floor.
There's
Now
no
it's
reference.
even more tough to find the canals. So
You know,
yeah.
that dentinal map, I always call it GPS.
Yeah.
GPS
Yeah,
to the canal orifice.
same
Absolutely.
GPS.
So
Absolutely right.
if you
True.
are lost, and if you are not having a GPS to your location, you are
Yeah.
going to nowhere.
Yeah.
Exactly.
Absolutely
100%.
right. But yeah,
Okay, so
there are. Yeah. Correct.
yeah,
Continue. Continue. Yeah.
is there anything that we missed while we're trying to access the canal, the chamber now? Did we miss?
Just before we go ahead, and I'm telling this because of experience. I have done my dentistry in India. I worked under an endodontist for 3 years while my brother was doing MDS. Then I went to Spain. I was doing consultations while I was not even an endodontist. So I have seen it all. It's not that I'm sitting in the UK. Okay, I've done
That
everything. I've seen it
happens
all,
only in India.
right? So yeah, and I've worked in Spain for 6 years, and I've come here. The thing that there are so many things that just blew my mind. As small as wearing gloves, as small as that.
Wait.
If you're,
Yeah.
I've seen, sir, size नहीं है. Yeah, we don't have your size. ये large ही है, large ही पहनते हैं, सब boss large पहनते हैं, हम सब large ही मंगाते हैं, you know, something like that. So an endodontist cannot have not fitting gloves in their hand.
Absolutely
I'm sorry,
right.
unfortunately. Or as small as your slow hand piece with the burr that goes inside. So we have spoken about so many beautiful burrs, yeah, and you put it on the hand piece and it goes like this.
Yeah.
Yeah.
How are you gonna work? It doesn't make sense.
Yeah.
Ultrasonics, for example, EMS, the tip is from satellite or the tip is from woodpecker. It's not gonna work. So have your armamentarium proper and then go ahead, because no matter what you buy, it's not gonna work if things are not in the right place. Sorry, that I just went a little off track, but let's get
Come
back
back.
to.
Yeah.
Yeah. So are there any specific settings that you use your ultrasonics at? Like, what is the speed you keep at while you're trying to find the calcified? What is the setting of your ultrasound? The
Uh,
what do you call it? The
someone
For me,
ultrasonic machine.
asked this
it's
question.
different. Yeah.
Someone asked this
For
question. So every, I think every tip I have come across a lot of students who say this कि सर आपने वो जो टिप बताई थी ना वो टिप हमने खरीद तो ली, but because they don't have the understanding of how to use a particular tip, because every tip has its own way of using it. So if you're using an ultrasonic tip with a higher frequency, it will definitely break, even if it is like 15,000, 20,000 rupees tip and it's like the best company and the best possible. You sometimes you need to take care of it, understand how the tip works. Usually it has to be uh, in the range of 3 to 7, 3 to 8, depending on where you are working. All right. So if you're working only in the pulp chamber, I would suggest you can go ahead till 8 or 7 or 10, probably, if it's a molar and it's a big tooth and you know that you need a lot of dental shavings that need to come out for a straight line access. And if
Yeah.
you are going into the canals where you are treating like a re-RC case, or like if you're trying to open up the orifice and make it a straight line, or for that matter doing your irrigation protocol and going into the middle third, the frequency and the power of that instrument gradually goes down. You cannot use more than 3. If you are going into the chamber, into the canal orifice, and at a speed of 10 or 12 or 8, no matter how good the tip is, how good the company is, it will break. So I will suggest where you are using it, which tip you are using it, that will govern the speed of that instrument.
Okay. So the range is between 3 to maximum like 10.
Maximum
So if you're
like that.
if you're unsure, keep it on the lower side. Like if you are unsure that how much pressure, you're a beginner, keep it on the slower side.
The
That's okay. It's
lowest
just
side.
yeah.
There
So it's going to cut
are a lot
less.
of videos. You can ask us. We are always available. It's not like we'll disappear from the grid. You can always get in touch with us and get to know that this is what I'm using and this is where I'm using it. So we can give you a range, at least 8 to 10 or 6 to 8, that you can use this. And if not, there are a lot of videos and tips which are available on the YouTube or the Instagram platform, wherever, on our Instagram as well. So we can always go ahead and search for it.
Yeah.
Just want to say that different materials are, sorry, there are different um,
Tips,
machines, and they have
machines.
different tips, and
Absolutely.
they all have different. Some of them are on the chair where there is no setting.
Oh yeah.
Yeah.
Absolutely, it just goes to the top.
In
So
India, it's like that. One setting on the chair, the ultrasonic
इधर
is
भी
like full.
है
यहाँ पे भी है. Yeah.
I think Tausif, you are missing India so much.
I know. Really want to come back. So there is I think, buy the tips, try it on the extracted teeth,
Exactly.
and check your setting for your comfort, for your magnification, for your whatever. It's completely fine. You
Yeah,
can
that's
go you can go to the full, you may be going to 2 and you may be getting the results. You never know.
So
Exactly.
it depends on
So
the
start with the lowest most, and then goes like as per your
Yeah.
comfort.
Yeah.
okay. Yeah, that's
right.
a good tip to start with. Okay, so we're done with for okay, so we're in the chamber. We are using ultrasonics, using under our magnification. So, okay, so you found the catch, maybe. Okay, you found a catch. So, how will you proceed for the preparation? Like, the start from the coronal third to the apical third. How will you proceed? You've just found the catch. Okay, like, yeah, this might be the canal. You'll take your RVG and you say, yeah, that's my canal. So how do you proceed with that after that? So yeah,
How do
who's
you
gonna take it?
how do you proceed and what do you expect are two different things. I feel that the expectation is कि मुझे canal मिल गया मैं एक file उठाऊंगा and I will go
And
till the end.
Hmm.
zoom.
Right? Zoom, like it's like Dhoom Machale. You have to go till the end. It cannot be like
And
that. I always
and
say this to my.
eventually I will need to take that file out, the
Yeah,
broken file.
absolutely. Yeah. Sir, sir, मैं क्या करूँ? Yeah, so
I
it
think,
is, yeah.
yeah.
Again, I feel it's kind of an understanding that you should have ke what type of canal it is and how to proceed, and there is a shift in the understanding that we started with. I think the step back technique. This was the first thing that was introduced into dentistry for preparing a canal, and now that we have the access to all the files that we have come down to hybrid techniques and the crown down technique. The problem when it comes to a calcified canal and a curved canal, you cannot expect, first of all, to get till the apex immediately. First of all, the conventional way is the best way. First of all, you need to keep in mind that until and unless you are done with the hand filings, be it 8, 10, 6, 12.5 भी आ गया है अभी तो, there's 15. So be it any hand file, till the time you are done with the apex locator reading, till the time you are done with your hand filings in the conventional way of preparing that micro glide path, you should not use any kind of rotary. This is what I would suggest, because as it is, the case is complicated. As it is, it has a lots of turns and ups and downs like a roller coaster. It is there inside, which we don't expect, which we don't anticipate. So I feel that we should figure out what we want. My particular personal way that I feel is a crown down technique. I think it's a very easy way to go into the canal and reach till the apex slowly and safely.
Okay. So you want to go by crown down. So
Yeah.
how do you prepare the coronal third? And then you what do you use your orifice openers, your SX? What do you use your
Just
GD drill? What?
How do you do it, Vishal? Dr. Vishal,
Hmm.
tell me.
Actually,
How do
actually,
you?
one,
I like to mention, like, are you guys using other than K files for this type of cases?
yeah,
Yeah, we are
Yeah,
using a different kind
yeah.
of
So
hand
we
files. Yeah.
have this very beautiful file, D Finder,
Mm,
and the another file is GF, I mean Glide
yeah,
Finder, right?
yeah.
From the money,
But
and the most commonly used like C plus from the
C
C
pilot,
Dentsply.
plus.
C plus.
C
Yeah,
pilot and C
even
plus.
the C pilot. So these all files are the heat treated files,
Mm,
what
Right.
we call in gross catheterization files, right? So if I am doing the case, I am not going to use K file straight away for this kind of cases. I will use first the D finder. Whenever as Atif said, first I need to make a micro glide path.
mhm.
So first to reach the apex, at least my choice of file will be always the
The hand
D
files.
finder.
Yeah.
Yeah, and hand files, yeah.
Yeah.
And to like especially to get the coronal third entry or maybe coronal third shaping or the body shaping of the canal. Have you guys used the reciproc blue? Are you guys using?
My God.
No,
All the
no,
time,
all
All
the time,
all the
can't
time.
can't
all
do
the
without
time.
it.
Yeah.
Can't do
So
without
I
it,
think
brother.
I think you know
What is that?
I always call this magical file.
Yeah,
You know, we
it
never
is.
Oh,
unbelievable.
unbelievable! Because once I have done my thing, once I've opened my access, and I just asked my nurse, I was like, magic file. She says,
Yeah.
she knows what it is.
She knows what it is.
But
Literally
Actually, we
the
don't
word
have
magic
anything
file.
else in the armamentarium. When we are talking about something like
yeah.
this, we don't keep anything else in the armamentarium. So
But
when it comes to,
prepare your microglide path, right? You're
yeah,
done
this
with
is all after
glide.
this. This is all, yeah, yeah.
Yes, after
This
this.
is
I
this is
mean,
all after we are done with the hand filing, the conventional filing, and we have reached till the apex slowly and steadily. This is where we can start preparing the coronal third, and we can then take our micro glide paths, which are rotary files, if you want to, or if you're going. Now, I just need to clarify two things. One is why we use different types of K files and by hand files, especially because we should have the knowledge whether these are passive tip files, these are semi-active tip files, or these are active tip files. Now, active tip files, they have the ability to break into that calcification and negotiate the canals. All right. If you're using a tip which is passive tip, which is not supposed to break into anything but only slide and glide into the canal, you may not be able to negotiate the canal till the
Right.
apex. So you need some kind of,
It will
yeah,
fold like the
yeah.
file will.
So the
Bakkan.
file will bend, the file
Yeah.
will have a lot of stress in it, and as Dr. Vishal said, that it will be referred to a nearby endodontist and we'll get a call. So something like this will happen, and the worst part is it will break in a situation or in an area which is very difficult to access, probably in a curvature or in a twist.
Or
So
exactly.
you
In
may
a way.
you may see that the canal is straight, but actually it's like a roller coaster. When you're riding a roller coaster, how you're going in the same direction, but you're rotating inside. So that is where you need some kind of active tape or a semi-active tape, which will glide you through that without any hindrance. So you should know your hand files as well, which is again what he said, D finders and C plus files and C pilot files. You
Yeah.
should know कि मेरे पास में active tip files है या semi active है या passive है.
Mm.
So you will get to know where to use it.
Yeah. So the active ones are C plus files and the pilot files and the defined
Yeah.
C
files. But
pilot is not active.
C
No.
I
semi
can
C plus,
differentiate
semi
between
yeah, C plus
C plus
active pilot.
C plus.
The VDW one is not active, right?
K
I'll tell you I can tell
file
you
is
the
totally
differences.
non-active file. The C plus and your glide finder is has active tip, and D finder has semi-active tip.
Correct.
The
It has
D.
a D cross section, yeah, right?
Yeah.
So
So
why
portion of it
I
is
see
active.
my preference, sorry, just my preference to choose this D finder is just to have another dimension. We need to think about the taper because it has very less taper, or what we call it taper less file or one taper file, right? So this
Yep.
is a very actually very good file to go into that apical part of that calcified part. I mean calcified canal, right?
Mm.
Taufik, what do you have to say?
Well, the difference is there's everything is online, so you can check the differences. Basically, the C pilot and C plus files are the C plus files are tapered, so and they have active tip. C pilot is just your K file, but stainless steel, more rigid. Okay, so you can use whichever you want, whichever works for you, whichever works best in your hands. No matter what file you used, but no, what file you use, the only thing is you want to make sure you're using either watch winding or balanced force technique.
Balance.
Probably the balanced force technique is the one that you would want to use for calcified canals.
Correct.
One tip I want to give you is run for the big one. This is what my usual concept is: run for the big canal. So if you're working on the upper molar, lower molar, run for the big canal. Once you find the big canal, which is the distal canal in the lower or the palatal canal in the upper, you will have a guide where the orifice starts.
Mm-hmm.
That's when you extend towards the other ones.
Yeah.
That's how you can find your map. That's how you can make your ultrasonic tips, even if they are very, very active, not go deep inside and perforate. That's one of the things. The other thing I want to say is don't rush to the apex. In any case, absolutely any case, even in a huge blunderbuss canal, please don't do that. What you're going to do is the only thing you're going to do is by running to the apex is pushing all the necrotic debris, pushing all the bacteria, everything into the apex. Don't do that. Even if it is a huge canal, the biggest canal in your life, go coronal third, irrigate, go middle third, irrigate, then you take the patency. That's when you take your working length. I don't take my working length until then.
Mm-hmm.
Believe me or not.
Exactly.
I just don't do it. Just go
So
with
so
my
I always
reciproc or whatever it is.
yeah. I always say this to my participants and students. Even an elephant can go inside the canal, though you will only use number 10K file. I mean, in routine cases, right?
Right.
Yes, yes.
Though, yeah, though it is so wide, but still you have to use your hand files first. And
Yeah.
for calcified cases, for especially as Tosif is missing India so much. So for Indian, our dentist, I think I need to say, me and Atif will say this: use a new file.
Hello, I'm so sorry. I don't know what happened.
I think, I think, I think Anu हाथ हो रहा है.
I'm so sorry. I
Oh,
don't know
sorry.
what
Yeah.
happened. Oh, I'm so sorry. We're back.
It's okay.
Yeah,
It's okay. Happens.
It's all right. It's okay.
everybody's back. Okay. So, yeah,
So
you
we
were
were
saying about the
about new files. We were talking
yeah.
something that you missed. We were
Mhm.
talking about new files, using new files.
Every time.
Yeah.
Yeah, every
Well,
time, in
just
fact.
right
Yeah.
every
That.
time.
India.
The reason for that, especially in the UK, is I can't even, unfortunately, I can't even use the same file for the same patient in the second visit.
No,
The problem
you
is
then you need to say fortunately, not unfortunately.
True.
probably, yeah, probably that's the right one. So yeah, there's something called as mad cow disease. That's one of the things. It is a degenerative disease. It doesn't go away with sterilization. That's one of the major risks. So anything that goes inside the canal cannot be used for any other patient, because you might be just transferring it to other patients, and then they might have a degenerative. It's not a bacteria, it's not a virus, it's not a pathogen. It's just a prion. It's one of the risks. So yeah, that's why the reason for that is not to use and only use new files.
I feel Indians, all the operators that
All
we are practicing,
have mad cow disease.
we should also think of we should also think of the same thing. It's not about that particular disease, but in general, cross contamination is the worst thing that you would expect, and the patient will ultimately suffer. And if it hurts us, because most of the time it happens that we are also in constant contact with these instruments and the diseases and the microbes, so we don't want ourselves or our kids or our family members to get the same kind of
Anyone.
infection. So please try your level best to use one file at a time and just throw it away. If you feel it is not good, you may need to charge more, but you cannot compromise on this factor, because that's the biggest question that we all have. Sir, best file bata do, and then the next question is, ये कितना चलेगी? अरे कितना चलेगी?
Best
एक ही बार चलाना
and
है.
economical. I
अरे
think I
एक ही
think
बार
these are
चलाना
the
है.
words, right?
Absolutely right.
So,
So stop
And
is
asking.
it a
and
good
and
option?
wait a second, Nano. I think, and as we are discussing about the preparation, I mean the shaping of the calcified canals. What medium you guys are keeping in your canal? I mean EDTA gel or sodium hypochlorite or EDTA liquid? I keep sodium hypochlorite. What about you guys?
I
Hypochlorite.
also keep hyper.
Absolutely no doubt about it.
No
Hypo.
EDTA gel.
Full concentration.
Yes.
That to full concentration. No
Yes,
no
exactly.
dilution. कि सर मैंने 5 ml का हाइपो में 2 ml हाइपो डाला और 3 ml सलाइन डाल दिया. No,
Yeah, it's
not
just
at all.
it
Makes no
is just
sense.
like a Dexter, Cartoon Network wala. Dexter from scientist. Yeah, yeah. So we will just become the scientists here randomly 1 ml sodium and 1 ml hypo, and now हमारा hypo will become 3% from 5%.
That
Rubbish.
I just wanna say one thing. Just wanna say one thing before we go ahead, for especially for the solutions that we are taking. No matter what solution you use, it's not gonna help you in negotiating the calcified canals. The problem is it's very simple to understand. There's something called a surface tension. That is why if you drop
You have a drop of
water,
hypo
a
water.
drop of water on a table, it makes a dome shape.
Yeah, the
Okay,
Yeah.
because it has a surface tension. It doesn't just disperse on the table and it's alcohol that does that. It's not water that's going to do that. So there's a high surface tension. Alcohol has a low surface tension. So imagine if that's happening on a table, what's happening in your small canal that is 0. Not even 0.10, 0.07 millimeters in thickness. Nothing goes inside there. Absolutely nothing goes inside there.
Yeah.
Your sodium hypochlorite is just helping you remove the debris, kill all the bacteria, dissolve all the organic tissue. They are not in contact in the end, the tip of your file, until you agitate it and make it work. एक आधा second contact होगा, but not more than that. So surface tension is something that you need to consider before, especially with gels. Gels have the highest
Yes.
surface tension. It will never reach
Exactly.
your apical part.
Absolutely. It's all here that you have used EDTA gel when you are
Exactly.
taking your file inside the orifice, but technically the gel only stays in the coronal part and your file travels alone.
The other
There's
point
nothing
is
that goes inside.
all files are made to take things out.
They're designed in that way. Yeah.
Yeah.
They're
To bring
designed
it
in
out.
that way. So I've also seen people using local anesthetic or topical anesthetic on their files, on their gloves, on their files, and then putting it inside the canal just because patient has pain. How is it going to work? It's never going to work because your gel is just going to come out with the file.
Okay, so
It's
while
not going to work.
using hand files, like for example, I'm trying to break through a calcification using my hand file. What about then coating EDTA gel with my hand file with the EDTA gel? Is it not useful then also?
What we all do, I think all four of us and all the endodontists who are listening to this or doing proper root canals, they just flood the chamber with hypo.
Hypo. Mm.
Exactly.
ठीक है
That's the
so
only way
जितना
to do it.
जितना आप prepare करोगे the hypo will go inside and hypo is
Inside.
something which is the first thing that you need in the canal, in the chamber, in the vicinity, because that is going to take your organic tissue, as Dr. Tausif said. It will dissolve it, and because of the file which is also along with that hypo going into the canal, it is actually agitating and making it touch all in all the areas and surfaces as possible, as much as possible. Hypo alone without agitation with full concentration also takes a long time to dissolve the tissues, right? Am I right? So we need
Yes.
some kind of agitation, the rotation of the file or the reciprocation or any kind of movement that happens in the canal with the liquid hypo or the liquid EDTA that will make it work. Mostly the hypo will take at least 45 minutes to 50 minutes to an hour without any agitation, without anything to dissolve the organic tissue. Why are we not waiting 45 minutes? Because we can't wait. That is why we agitate. That is why
Yeah.
we activate the hypo inside the canal so that it activates itself, releases whatever the tissue and the surrounding microbes are there, because it's not going to work on the smear layer, guys. It will not work on smear layers. EDTA at the end will work on the smear layer, and again EDTA gel nahi, it has to be EDTA liquid. It's just a 250 rupees bottle which expires before it finishes. So, so please buy and start using it.
Yeah.
This is
So somebody
typical
Even
just
Indian
asked,
mentality. Yeah,
yeah,
EDTA
somebody
liquid
just asked
liquid is actually as important as sodium hypochlorite, I think.
absolutely,
yeah,
absolutely.
for the smear layer
But no
because
normal
hypo
saline,
does
no
nothing
EDTA.
for the smear layer.
No, no.
Hypo does nothing for the smear layer, so you need something for the smear layer as well. Correct. So
Hypo will
somebody
have.
just asked, yeah, somebody just asked like, why are we using the highest concentration of hypo? So that the answer you just gave, that if you're going to use the lower concentration, you have to expose the root canal for a longer period of time, and if you use the highest concentration, you will have to expose it for the less amount of time, like 20-25 minutes is okay. But if you're using less, then you'll have to irrigate more, have to expose more to completely get all the organic debris and the pulp tissue out. Okay, so yeah, I think we have covered a lot of it, right?
Yep.
Yeah, we
The
have. We
yeah.
have. I think the only thing, one of the things that I would want to say is, if you have found the canal, and if you have found the canal with the, of course, our apex locator is all the time attached to your file, even if rotary, if possible, please. I have the one that's integrated in the motor, so I think Atif also has that. So all the time has to be attached. You have to have your pre-endo build-ups. You have all the basic stuff. Speaking about, because this is negotiating calcified canals, and that's the live, but what's it's about. So once you have found the canal, go with your rotary. Once you've found the canal, you know that this is the canal, you've gone to the middle third, go with your rotary, do the coronal flaring, make it wide, remove all the obstructions, open the canals, open the access cavity. Don't worry about having a minimal access cavity and looking at Instagrammers like us looking at truss accesses and stuff like that. It's just because we like it, we do it for fun. Don't follow us as in that sense. Open it up, it's fine. You need to see what you're treating. If you can't see what you're doing, you can't treat. And then you take your 10 file again, or 8 file, or 6 file, whatever you're using. Go a little bit more. Take your rotary again. Go a little bit more with your hand file. Take your rotary again. And at the end, when you are in the middle third, that's when you go to the apex. That is how you negotiate
So this
calcified
is
canals.
one question I have. You said about using the apex locator attached with your rotary file. So you use that same apex locator for your, I mean, the working length determination, or use a static way, like introducing a 10 number K file, or the
So
static way, or
I
use
have
it the dynamic way?
both ways. So I have the machine that has the apex locator integrated inside it. It has the clip as well to attach to a hand file, and it also is integrated automatically in my motor. So as soon as I take my file, it starts beeping. But before I didn't have that. I had the X Smart Pro from
My
Dentsply,
plus.
whatever it was. Yes, the plus, and I used to use the clip on the rotary file. The problem with that is it reduces your torque. It holds onto the file, so it reduces your torque of the file. If you're using a rotary file, you can increase a little bit of your torque to compensate for that. But if you're using a reciprocation, you might not be able to compensate for the torque.
Okay. So for how I go, I just take working length at the initial, then before obturating, I don't do the dynamic thing. I discussed it with Dr. Vishal also before. It's discussed in the last night that working length, the apex is static. Like, okay, so you're just doing it so that you don't over prepare at any point of the time, because as you come in contact with it, it will start beeping. That's your, yeah, go
So
ahead.
I'll just add on to this that since we all are using hybrid files, wherein all the files, whichever file, if I give you an example of ProTaper, it's S1, S2, F1, F2, correct? All the files need to go till the apex. Even if it is not preparing the apical third, F1 is the first file that prepares the apical 3 mm. S1 and S2 will never prepare the apical 3 mm, but it will only prepare the coronal and the middle third if it goes till the apex. It has to go till the apex. That is how it prepares the coronal end. So in this situation, we need to 100% go and take care of the apical working length, the coronal working length in the beginning, and then follow that routine for all the files. You can go up to F3, F4, 4006, 4005. You have to follow that working length, correct? But when you're doing a crown down technique where you're not reaching the apical end immediately, hand file say 100%. You are preparing the glide path, you take the working length, that's fine, just for your satisfaction. But when you are preparing the canal in a crown down fashion, you're not reaching the apex every time. You're only clearing 2 mm, then irrigating, then 2 mm, then irrigation, then 2 mm, and at the last uh, uh, reciprocation movement is when you reach the apex. So in that situation, even if you have a clip attached and the apex locator which is integrated into your endomotor, will definitely work. So it depends on what we are choosing the file, because it makes sense that if you're not going till the apex every time, every pecking motion that you're doing is not till the apex and it's a crown down technique, it makes no sense to like think about the working length immediately. But yes, in the first hand file, and if you're using it for the first time and you have reached the apex, you take it for yourself if you're not using single file system.
Okay.
You can do that.
Yeah,
And then
and I think to add on this, what we can do before using our master apical file, we can take another working length. I mean that will be
absolutely,
our final working length.
absolutely,
So
yeah.
I think, yeah. So I think as Dr. Tausif has mentioned, we have to attach our leap hook always and always till we obturate, right?
Right.
For this type of cases, and especially for curve and the calcified cases. Because working length tends to get some sort of like reduce from
It
the
will
initial
reduce.
working
Yeah,
length.
yeah.
Yeah, because you are actually making the path straighter and
Straighter.
straighter. And as
Yeah.
the physics says, the distance between 2 points will be shortest in the straight line, right?
Correct.
So this is actually we are making some kind of straight portion in the canal.
Length will.
So what I do, if I'm using reciproc blue, I will straight away go till the middle third, and then I will take the file out, and now I will introduce the 10K, I mean the hand files, and I will try to negotiate. Once I have the apical part prepared with my hand file, I mean the glide path preparation has been done. Now on that working length, I will use my reciproc. Right,
There you go.
Tosif? Right? What you
Absolutely
do?
right. Absolutely right.
Sir, just come here, take my job.
Oh no, please. I love.
I did the same thing.
I
I
think
did the same thing.
me and Atif will forcefully bring you here as you are
I'll come
missing
back.
India.
Uh,
But
But
reciproc blue, I think someone has asked also in the question box that which file do you guys prefer for calcified and curve canals of molar? I think reciproc blue is one of the magic here.
one of the magic
See,
files,
we
yes.
have rotaries, and we are not saying that rotaries are substandard or rotaries you should not use. But once you use reciproc blue, I think you will not go back to the rotaries, especially for this type of cases. Especially,
But
yeah.
sometimes, yeah. Sorry, Vishal sir. It's just sometimes that I've started using a different smaller taper file before using the reciproc if I have to, because the canal is really calcified or is really tight, or I want to make a glide path before that. So sometimes I use that. My preference is rotate 20 or Tunatomy, or any file. You can use whatever you want. Basically, the whole point is to have a smaller taper, 15 or 20, or you can even use Pro Glider. You can use whatever you want. Once you have your 10, 6, 8, 10, 12, 15, whatever you want to use, hand files, once that's down there, reciproc is going to go for sure. But if still you want to make sure that your glide path is clear, you can always use something that is a smaller taper, smaller file, to just clear out the path,
Yeah.
and then go with the recipe.
So I think we all understand this, that working length is so crucial. Working length is so crucial. But in especially narrow canal, I mean narrow like calcified cases, or maybe when there is very narrow canal, or maybe curve canal, we need to understand one more parameter, and that is working width. Right? And
Absolutely.
that
Yeah.
and that actually,
we need another life for that.
Absolutely.
yeah, and that actually we have to achieve with our hand file.
Mhm.
So whether you are using rotary or reciproc, at least prepare your apical third first with your hand file, and then go inside with your rotaries or reciproc. But that all we do, right?
Yeah.
We all do that.
Yeah.
Yeah, yeah.
Mhm.
Yeah, yeah. And
So
keep the canal patents are all the time.
this is I think the take home message for the audience, that yes, you can use your file, your chosen or your favorite file, or maybe reciproc blue, your rotaries, pro taper and everything, but at least prepare the space first with your hand file, and then go inside with your rotaries or reciproc.
Yeah, just 10 number is enough. Like you don't have
Enough,
to
more
work
than enough.
in or anything.
Yeah.
Just 10 number, a smooth 10 number that you introduce it, that it goes up to your at least your apical third nicely and smoothly. Then you can proceed with the rotary. Correct.
Absolutely.
So yeah, I'll take some 10-15 minutes for questions. So we had a lot of questions, but I'm going to keep it a little relevant, a little towards the topic that we're talking about. So we've talked about the liquid EDTA, the apex locator. Then do you want to talk about agitation time? Like how much time do you give for agitation to each canal? For 30 seconds, I
30
guess.
seconds
30 seconds.
each canal activation, whatever activation you want to use.
Okay. Then somebody's asking, in every case, should we use EDTA liquid, irrespective if it's a calcified canal or it's a non-calcified canal?
Irrespective.
Yes.
Irrespective. You have to.
Simple answer, yes.
So the
Label.
logic is whenever you have used any metal inside the canal, I think you need to use retail liquid, because it will create some kind of debris,
Smear.
your smear layer, right?
Smear layer. Yeah.
Yeah.
and we call it accumulated hard tissue debris.
Cause of
And that,
us, what we are using.
yeah, because of us,
Hmm.
that gift we have given to the tooth, and that
Yeah,
tooth does not want that. So
yeah,
I think whenever, if it is a normal case, you need to use EDTA liquid,
Mm-hmm.
And then use sodium
sodium
hypochlorite, because
hypochlorite. Yes, perfect.
once you have removed all that debris that has gone into the apical
Tubules.
constrictions and all the
later
tubules
lateral
and the
canals.
lateral canals, once you have used EDTA, that's going to go out.
Mm-hmm.
You introduce your sodium hypochlorite again, because that's when it's going to go there and clean out everything. You agitate that again.
Absolutely right.
And I think Anu, you got one more topic for the next live, irrigation.
Yeah.
Yeah, my God.
Before
We can talk
doing it,
about it all night.
wanted
Is that good?
to part good our curvatures, working through curvatures, the multiplanar curvatures, the fine apical splits. We are going to talk about that in our part 2, which is going to be very soon. Right. Yeah. Okay. So to give a take-home message for the tips for locating the canal orifice, we missed out on using how to use dye to
Yes,
Yeah.
look.
Dye
methylene
and
blue.
champagne test if you want to
Mhm.
use it.
Yeah, so this both of these will be helpful once, as Charles has said. Under magnification, champagne test
Again.
will be helpful for champagne or magnification, and same goes for the dye method to use find the. You just how do you use the dye and how much does it cost? Talk about it a little bit. Who's Vishal sir? How much does it cost? The dye?
I think, but I'm using that CDD only, Caries detector dye only. Which one you are
This
using? I'm
thing,
using from
yeah.
Kurare. I'm
Yeah,
using from Kurare. I think the red one.
Curare
yeah, yeah.
but if you want to add something very um it's like adding a, what do we call it, I don't know,
So,
a small thing,
so yeah,
small
so I think how you can use your this staining dyes, and what is the dye method to find canals for this type of cases. So the logic is this dye will eat, or maybe dye will stain the tissues.
vital
So
tissue.
if you are not able to identify between the pulpal tissue and the healthy dentin tissue, this dye specifically will stain the pulp tissues or the areas above the pulp tissue. And now under the magnification, you will have some idea. Once you apply this dye, keep it for 3 to 5 minutes and just wash it with the water. And now you will have some stained area. So this is your target area for this kind of cases, right? And now with the Mons bar or your ultrasonic, you'd start roughing particularly to that area.
Mm-hmm.
And even this thing you can see under transillumination also. If you just use your curing light, once you have used the staining dye, and if you are using your curing light, you will see some kind of different area. If you are not using your microscope, see under microscope you have that filter, different filter, right? So green and the natural white filter, you will see this, right? But if you are not using scope, you can use that curing light, and that will differentiate the area. So the target area is always the darker area.
Mm-hmm. Yeah.
That once upon a time there was a pulp at that area. Now, because of the dentin deposition, calcium deposition, the pulp has gone, right?
Mm-hmm.
So we
There's
need to
still
find that
some
area.
organic tissue left, which the dye will stay.
Exactly. Yes, the dye will eat. I mean, the dye will stain that area.
Okay. So
But
I think we.
but this all are things, we can discuss on this. I think Tosif will agree with me, and Atif will also agree with me that we can say on white line test, white dot test, this staining method, this champagne bubble test, but everything has to be under some kind of magnification, though you
Yeah,
100%.
accept it
obviously.
or not. Cause though we can speak for hours and hours, but ultimately when you are going to do, and if you are not under any kind of magnification, you will be just blank.
Mm-hmm.
मार्केटिंग टेक्निक में बोलते हैं दिखेगा नहीं तो बिकेगा नहीं. करेक्ट.
Exactly.
प्रोडक्ट अगर दिखेगा नहीं तो वो बिकेगा नहीं. तो आप भी इफ यू आर यूजिंग एनी काइंड ऑफ टेस्ट और एनी काइंड ऑफ way to know this, if you are not able to visualize it, you won't be able to see it.
Exactly.
Yeah.
And then
Yeah.
then then ultimately फिर बर लेके कर दो शुरू
वही होता
digging.
है, यस, आरडीटी की धज्जियां उड़ जाती है फिर. व्हाट हैपेंस इज देयर इज नो रिमेनिंग
And then
डेंटाइनल.
and forget about RDT. On top of that, we will save the tooth with zirconia crown. What rubbish.
Prosthetics is a completely different
That
So,
topic. We
completely.
endodontists should talk about that later on.
सर प्रोस्टा वाले भाग जाएंगे सर, क्या कर रहे हो?
अरे सर, आज हमारा सुन के प्रोस्तो वाले, OMR वाले सब भागने वाले, and they will unfollow us.
Yeah.
So there's one last question, that is the filing mode. A little bit about that the balance force technique, or the watch winding technique. When you're trying to work through a very fine canal, you'll use your small watch winding. But when you're trying to increase the length, or when you're trying to break through a calcification, you use your balanced force, right? Any
Well,
you guys?
I mean, they both are different. They both are. I mean, watch winding was given before, and balanced force was to overcome all the disadvantages of watch winding. So I don't. I mean, I've always used balanced force most of the time. So you turn anti-clockwise 90, you go 100, 180, 270 with an apical push, and then pull it out.
Mhm.
That's what I've been doing for almost forever for everything.
Okay, even for when you're trying to, for example, when you try to, what do we call it? When you, sometimes we have to wiggle the canal. Where there's no, it's not, that's not that it's calcified, but it's the size
There's a
is small.
catch.
Yeah. So that time you have to wiggle it. So I prefer using watch winding and balanced force intermittently, like on and off. So anything that
So
you
what?
guys want to add?
Whichever way works for you. I think Vishal sir wanted to say something.
Yeah.
Yeah, and I think whenever you are using that kind of C plus or maybe Money's Glide Finder,
Mhm.
right? Or maybe Oricam C Pro kind of files, that is the variable taper hand file. You know, the base technique at Dr. Tosif said, balance force is very good and actually very well work with this kind of files. So
Mhm.
if you are just rotating it, it will break within
Yeah.
like a few seconds, but you need to have just like of clockwise, anti-clockwise with slightly apical pressure, and then just pull slightly
Pull
and
it out.
then go back again.
Mm-hmm. So it's
So
cutting while it's coming out. Mm.
Exactly,
yeah, that's
it's
what.
cutting in actually in
It's basically
anti-clockwise, right?
reciprocation.
Yeah,
It's
basically
basically
reciprocation.
reciprocation.
So the when canal diameter is very narrow, when you do not have any free space, and if you are rotating a screw, what will happen? It will go inside, but it will not come out. Same happening with our rotary or maybe hand file. So we need to just go like watch wind, watch wind, watch wind, right?
And
And
then you.
this is why I think Reciproc Blue will have some new name after our
Magic.
this Insta Live magic file, as Dr. Tausif
Yeah.
said that.
Magic file. Yeah, so only
Yeah.
two. So I will just give you the same input. Two things. Whenever you're using any hand file with any kind of movement, be it watch winding, be it anything, the going in will always be an engaging portion, and
Motion.
coming out is when the dentine is cut. So if you're just engaging and going thinking, okay, I need to reach the apex immediately, you are just engaging it. But if you want to actually give your canal a proper glide path, you need to engage couple of come out so that it cuts that dentine and the debris are out in that hypo liquid which is there, which is present throughout, and then slowly go in and come out, slowly go in and come out. So I always tell the operators who are in a relation or are married and have kids are much better endodontists than the others, because they have a lot of patience. You need patience. You just cannot think that it will directly go in till the apex in one go.
Mm-hmm.
So please
You know,
be
I
a little
I
more.
love I love I love Atif's courses. He finds these funny. I don't know
They're
from
relatable
where he gets
comments.
these relatable comments.
These are
His
relatable
courses are
comments.
the funniest. He is always
Thank you.
really good.
Uh,
Yeah. So any other question?
Uh, actually, mm, there are some recommendations for endomotor with integrated apex locator, but yeah, you wanna cover that in like
There are a couple. Yeah, I'm just gonna say some names. The recent ones that I think one of the Dentsply one has recently come up with a new one, but I don't think it is still available in India. There's another one that's available which works with the iPad. I wouldn't be very keen to go that because then you have to invest in an iPad. So, but it probably soon will come to India as well. It's a very good apex locator integrated motor. The other one that I use is the VDW Gold.
mm,
That is
It's
the
one
gold
of the
standard.
best. It's one of the best I have seen. The battery is fantastic. The motor is it just has everything. It's just perfect. The Dentsply one is basically similar to this one. It's just a little wireless stuff and a little bit more. It has a light on it and stuff like that. So it's just a bit, and they both are the same company anyway.
mm,
Dentsply and VDW. Then you have the other ones that you have. I think that's one coming
Morita.
from
J
J
Morita also
Morita.
has. Yeah.
Morita has one, and the other ones, but then they don't have the reciproc and wave one gold setting. So
Yeah.
depends on what file you're using and stuff.
Two things I want to add to this. If you're thinking of getting an apex locator integrated endomotor, you make sure that it should not be a cheaper version of the endomotor and the apex locator, because apex locator is apex
fine.
locating the apex, finding the apex is the most important and the challenging part. So you cannot compromise on that. Second important thing is, if you are again thinking of the same system with an apex locator and you are keen on using both together, it cannot be used without a pre-endo buildup and without a rubber dam. It will make no sense. If you're thinking I'll just put a clip without anything, I'll just take the endomotor inside, it will give you fake readings, because it will, even if it touches the saliva, gingiva, lips, tongues, anything, it will give you the apex reading, and it has an automatic stop inbuilt in it. So it will stop, it may probably stop in the middle third telling you कि मेरा apex पहुंच गया. It may not be an apex, it may be a fake apex. So all these things considered, if you are thinking of getting into an integrated apex locator endomotor, please follow all these protocols and then use it, because then you're eliminating all the false positive, false negative readings that you may get.
Yeah.
Even under the rubber dam,
Sometimes it happens. Yeah.
Mm,
if it touches your clamp, that also can give you a wrong reading.
Yeah.
If you're going through crowns, it can
Rounds.
give you a wrong reading. If you don't have a proper isolation, if you haven't done a deep margin elevation, if you haven't removed the
Again, yeah.
cage. So again, all these things are basic endodontics, the basis of endodontics. If you don't have four walls, you're not going.
mm.
You cannot do a root canal.
Yeah.
Simple as that.
Okay, so we've been over 90 minutes.
So,
It's been
oh,
Wow.
1.5 hours. That was a great session though, and I think 100 people stayed with us for 90 minutes straight. That
that's
was
good.
Good
Commendable.
number.
Thank you so much, guys.
thank you
Thank
so
you,
much.
guys.
I hope it was worthwhile. We tried covering a lot of it, but there are some things that need time. So yeah, for the part two, where there's
And
like
I think Tausif Hatif, this is fun. I think we need to do this regularly.
Yeah,
Absolutely.
And
yeah,
once
100%.
me
Absolutely.
do
and
not
me and Tausif
get
has talked in
Thanks,
Instagram
Sonu.
also, right? Tausif,
Yeah,
you remember?
I
Yeah,
did message you. I didn't message you, and then
yeah.
finally we are here. Look
yeah.
at that.
So you
That's
will not
crazy.
get me. I
Thanks,
will.
Sonu Kriti. I was just telling that. Thanks to
Yeah.
That's
you,
exactly. Thanks to
So
because
you.
you
Thanks to
brought
you.
all of us together.
I think we have missed her introduction today. She has
Oh,
introduced us
yes.
each and
Oh,
yeah.
yeah.
So I think I will take the job, and right now with us we
Go
have
ahead, sir.
Instagram Endoguide.
Oh,
Wow.
And she is having very good number of followers, and she is doing some great worwork.
Thank you
And
so much.
and especially,
I tell her always that you are going to be a star.
Uh,
uh,
और हम तो अभी
and
हमारा खत्म हो गया, अभी हम
and
बूढ़े हो गए.
what?
throughout and throughout
Uh,
she has been so humble, knowing everything and anything what we are speaking, and she agrees to probably most of what we have been saying. She has been so humble and asking us, sir, EDTA gel what to do.
Yeah. And the last thing that I want to tell is that we all are enjoying this live in a comfortable home, but she is somewhere in a function, but she took time
Yes,
and she
Oh,
is taking care of us and the entire participants along
commendable.
with whatever function she is at, and she's gonna, I think, join that function soon. And I think that's commendable.
Thank
Commendable.
you, guys.
That's a commitment, yeah.
Thank you so much.
Thank you, Anukriti. Thank you so much. And
thank you,
Thank you,
guys.
guys.
Joining
anything,
Nice meeting you.
everybody for
yes,
part
right.
2. And it was such a great session. Thank you. Thank
Thank
you
you.
so much
We
for
shall do
coming.
it
Yes,
again. We shall do
Yes.
it
yes.
again.
Yeah.
It was so. It was a great session. Thank
You
you.
guys
Yeah.
do it again with the Vishal.
Yeah.
Okay, and before we end, I think I asked Anu this, are you guys twins? Tausif and Atif.
No, why?
No.
No, we are.
But
It's 4 years elder to me.
you two look literally like 20 number K and H
Why?
file, you know.
A good way to analyze it. That's so good.
Because
He just
a new
reminds
nurse,
me.
a new nurse in our operatory, she will not able to, like on the first day of itself, she will not able to identify between 20K and H. You two guys look like the same
Same like
only.
that. That's so good. I don't know if I
I
should take
can.
this as a compliment or not, because we can be in a lot of crimes together.
I
In
The
one
good
understand.
one
thing
crime.
is, the good thing is, I can see my future. I can see my
Yeah.
future.
Yes, you can see the future.
Super
Hair
soon.
loss,
Super
graying of
soon.
hair. So he has a mirror. He has a futuristic mirror in front of him.
Yeah.
Oh my God.
Anyways, we had a great time,
Yeah.
guys. Thank you.
Yeah.
Thank
Great
you,
time.
Anu.
Thank you,
Thank
sir.
you so much,
Thank you,
Thank
guys.
you.
So
Anu,
I'll
again.
save this live and then tag you all.
Sure.
So
Yes.
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 And
Okay.
have
Bye
a
bye.
Take care.
wonderful Sunday, everyone.
I think if we can take a screenshot, we all
Yeah.
together.
Yes.
Yeah. Someone
Yeah.
can take it. Let's Anukriti take it.
Okay. So are we doing something or we're just
Yeah.
smiling?
Yeah.
Wish I
Let's.
had a reciproc.
Reciproc the magic. Ghassan Arad will be so happy.
He will be there. Yeah, tag him. Tag him. Probably he'll share the reel as well.
Yeah. I will tag him. I will tag him.
Yeah.
Yeah, I will be very happy.
Anyways, bye bye guys. Bye bye.
Bye.
All
Bye
right,
bye.
guys.
Take
Bye
care.
Thank you
bye.
Have
Have a
everyone
nice
for
fun.
day. Bye bye. Have
Have a
fun.
good day.
Yeah. Good day.
the day.